Hello, everyone. I'm Leon Scott. I'm one of the attendings, the non-surgical sports medicine attendings. We are doing our first journal club on Tuesday, August 11th at 6 p.m. via Zoom. And I wanted to take the moment to, one, introduce myself. I haven't met all of you, but also to go over the Diagnostic Study literature review form. I'm going to send this out via email. So when you get this video, you'll have this link too. We've done Journal Club for 2 years. We have focused primarily on treatment studies, and this will be the first diagnostic study, or at least the study that allows us to answer a diagnostic question. So I wanted to make this video so that we can have a little bit of a background. So we will be answering the question if echocardiogram adds extra value as a universal screening tool in finding structural and electrical pathologies associated with sudden cardiac death in athletes, more so than our standard screening at Vanderbilt of history, physical, and EKG. We have the 4 papers that were sent out earlier this week, and I wanted to set a few ground rules. One, when we do get to calculating the likelihood of having and the prevalence of having a certain disease or cardiac pathology, we will be using a uniform pre-test probability. So pre-test probability is just the prevalence of disease within a population. So although sudden cardiac death in athletes happens in about 1 in 50,000 athletes, the probability and prevalence of the structural and electrical abnormalities associated with that is actually higher. So for us, it's going to be 0.5%. So 5 out of 1,000 individuals have findings that can be picked up through evaluation, and that we're trying to pick up with our pre-participation exams. So that's our pre-test probability or disease prevalence of 0.5%. Okay. The definition of these disorders, I want to make sure that we're all working with the same definition. We are looking for the electrical and structural pathologies associated with sudden cardiac death. And the best overall description of that is actually in the Malhotra paper from New England Journal of Medicine, where we will be looking for hypertrophic cardiomyopathies, arrhythmogenic right ventricular cardiomyopathy, dilated cardiomyopathy, looking for coronary artery anomalies, bicuspid aortic valves with aortic valve pathology like dilatation, long QT syndrome, and pre-excitation or Wolff-Parkinson-White. The presence of T-wave inversions alone, although an abnormality that would be caught on screening and lead to further testing, is not in and of itself a risk factor, or is not a finding associated with sudden cardiac death alone. The presence of Brugada syndrome may be, if you are found on stress testing to have some other atypical electrical malformations that occur, but ultimately the presence of Brugada can be evaluated, is found and evaluated in some of these studies, but is not found in others. So actually, to just clarify, let's put in the presence of Brugada syndrome also in that category. It just has to be evaluated further still. Wolff-Parkinson-White, you may say, well, you can treat that with ablation, and that is true, but we would consider that a risk factor for sudden cardiac death if it wasn't previously found and treated. So the list from the Malhotra New England Journal of Medicine, Table 2, and the inclusion of Brugada syndrome. All right. So we went over the pretest probability, went through the diagnoses, and that should take care of those common definitions that I want us to make sure we have. Also, oh yes, another common definition, the gold standard. So the gold standard here, if you screen positive in any way, you will go through a host of tests until a diagnosis is identified. So the gold standard is actually the presence of history, physical, EKG, echo, Holter, and a cardiac MRI. So not everyone gets all of those, but it's the collection of all of our diagnostic knowledge in cardiology that eventually defines and describes the diagnoses within these papers. But what we're trying to see is if you get screened with just a small subset, would that find eventually those issues? So there's not a single gold standard. There's not a blood test that defines it. It's more the total collection of all the diagnostic tests that can be done. As you're going through your form, you may say, well, that's incorporation bias. And yes, it is. By definition, that is incorporation bias. For someone to eventually get the cardiac MRI, they probably started with an EKG and an echo. So yes, that is incorporation bias, but that is one of the inherent flaws with these type of diagnostic studies. All right. So now what I'd like to do is describe how I envision our presentations. And this is less so for Jared Willard, who has experience, and I'd like for him to present in his way because he may have some additional data he wants to show us. But for the first year fellows, you will start by going through your diagnostic form, reading through the title and the going through study design and level of evidence. And then for the gold standard, mentioning the different tests that are used. Some of these tests do, some of these studies do use eventually for diagnostic purposes, cardiac MRI, and just having that all listed out. And then describing your population. So that's fairly basic. Then when we get into, before we get into the rest of the form, I actually want you to present the results or a summary of the results that the author stated was their primary aim or the answers to their hypothesis. Not every author posed a true hypothesis. They may have instead stated as a purpose or an aim. So I want you to give that summary. That summary should be no more than 5 minutes. I want us to work on succinctly describing what the authors say. Truly, it can be done in less than a minute, but some of these papers do try to touch on a number of different topics in a cursory way. So will allow us that 5-minute window. But then after that, the rest of the paper, I want us to go through, or the rest of the form, I want us to fill out as if the paper was designed to answer our question. What is the, can echocardiogram add significant diagnostic accuracy to our screening examinations? And I believe we were looking at, I may not have said this in the email, a 5% improvement in the post-test prevalence of disease. Essentially, does history, physical, and EKG have a specific post-test probability of identifying issues? And is the post-test probability with echo, does that add at least a 5% improvement in that probability? Okay. the way that we do that requires us to identify the sensitivity and specificity of all these tests. And although the papers do not, except for one of them, highlight the sensitivity and specificity of the history, physical, EKG, and echo, all the data is in the papers. It's just not listed in a nice, neat table. So we have to do our detective work. So in doing that detective work, you'll be scouring through the paper, and I am a resource. Please reach out to me if you're having difficulty or questions about that. I've gone through the papers and found that data. So we can, I can be helpful in clarifying if there are questions. But as you're doing that, you'll fill out these tables, and as an example, don't look too deep at the numbers here, but I set one up for EKG and one up for echo. And this one for EKG really should include the data for history, physical, and EKG all as one, because that's the current screening process that we use. Okay. One small aside, specifically in the Malhotra paper, you may notice that for disorders like arrhythmogenic right ventricular cardiomyopathy, that the history found one individual, and EKG found another individual, and echo found two. But we don't have a way of knowing if the one from history and the one from EKG were separate people or the same person found twice. And just to keep this as stringent an analysis as possible, if there's overlap, assume those individuals are the same person. I want to be as stringent in our assessment of our current screening process, history, physical, EKG, as with the addition of echocardiogram as a universal screening tool. All right. As another quick aside, you may be saying, well, if someone's positive on EKG, wouldn't they get an echo anyway? And the answer is yes, they would. But this is testing if echo for every person in the evaluation bay. So not just the one person who has an abnormality out of 10, but all 10 people getting echoes, in case that didn't come off as clear in the ways the papers were originally authored. Okay, so I'm going to now switch screens. And the screen I'm going to is a slide from a presentation on how to review these accuracy metrics. So hopefully you have your paper in front of you or a split screen setup. And in the section for results, we have a single table that helps you create a sensitivity, specificity, ultimately a diagnostic metrics matrix. The definition of all the useful accuracy measurements are below, but we're going to use a real world example so that it hopefully makes a little bit more sense, okay? So our example is going to be if someone comes into your office with knee pain, okay, so not related to cardiac, but just a way of using these metrics, what is the probability that a person who is coming into your office with knee pain has a meniscus tear? Okay. Well, if we are looking at this patient as they walk in, we already know, because this information is known publicly, that there's a prevalence in the adult population of 19% of all adults having meniscus tears. That may be different in certain age groups, but 18 and above, the prevalence is 18% of adults have meniscus tears, even if they're asymptomatic, okay? When we look at different tests, we can look at an MRI as a way of testing if someone with knee pain has a meniscus tear. We can do physical exam tests like the McMurray's to see if someone has symptoms consistent with a meniscus tear. And you may think in your mind that in absolutes, if they have an MRI that shows something, or doesn't show something, that they must or must not have a meniscus tear. But we know in studies that do MRIs and then subsequently have arthroscopies that the sensitivity and specificity of an MRI for meniscus tear is 100% sensitivity or true positive rate, and an 88% specificity or true negative rate. McMurray's exam, you may think, oh yes, if someone has pain, if I am rotating the tibia on the femur and I feel a painful pop, that must mean they have a meniscus tear. The sensitivity of that test is 70% in the, so true positive rate, 70%, and the specificity or true negative rate is 59%. So if we know the pre-test prevalence or pre-test probability of 19%, then we know the odds, which is 19 over 81 for a total of 100%. 19 over 81 is a 23% odds, okay? Or a 23% odds. The likelihood ratio that you have a meniscus tear is based on the true positive rate and the ratio of that to the false positive rate of a certain test. And the false positive rate is 1 minus the true negative rate. So for an MRI, the likelihood ratio comes out to 8.3. That's 1 divided by let's see, do my math, 0.12. The likelihood ratio for McMurray's is 1.7. So that would be 0.7 divided by 0.41. All right, so once you have that, then you can determine your post-test odds, which is the pre-test odds multiplied by the likelihood ratio. And if you are doing multiple tests, you just multiply the likelihood ratio of one by the likelihood ratio of the other by the likelihood ratio of the other. So it's a product of the pre-test odds and all of the likelihood ratios, okay? Of note, if you're looking at the likelihood of, if you have a negative test, you can do that doing the negative likelihood ratios, but that won't be what we're looking at in this assessment. So once you have that, then it's a little bit more math to determine the post-test probability, and that is going to be the, I believe it is the post-test odds divided by brackets post-test odds plus 1. And that would give you, in the case of this example, 0.65 or 65% chance that MRI alone with knee pain, so a positive MRI, and a person saying they have knee pain, they have a 65% chance of actually having a meniscus tear. You may go, oh, but they have a positive MRI. But the thing is, if you went into and performed a scope, it's really only 65% of the time that would truly be positive. So that's very interesting as a mathematical way of predicting the likelihood of something being there, the probability of something actually being there if the test is positive. If you just did a McMurray's test, so that's 0.39, sorry, the post-test odds is 0.39, so the post-test probability is 0.28, 28%. The sum or post-test probability of MRI and McMurray's test together is 76%. So if someone has pain, a positive McMurray's and a positive MRI, 76% chance that they have a meniscus tear that will be treated with surgery or evaluated surgically. Okay, so what I want us to do is to go through the post-test odds of our current screening, and let me rephrase that, the post-test probability of our current screening technique of history, exam, and EKG together, as compared to the post-test probability of those with echocardiogram, and identifying is echo adding additional value, specifically increasing the post-test probability by 5%. Okay, so we'll each present that from our study, and then we'll take an average of it, and we'll see if we think adding echocardiogram, not just as a final diagnostic tool, but as a screening tool for all comers at a pre-participation evaluation is worth it. And I think this is going to be a really, really interesting assessment. Yeah, I look forward to it. I look forward to your questions, and we'll move forward from there. One quick note, if your paper does not, and not every paper has this, although every paper has the EKG data and the echo data, if your paper does not clearly list out the history and physical exam sensitivity and specificity numbers, then we'll just use the EKG numbers versus the numbers of from EKG and echo. All righty. Any additional questions, please don't hesitate to reach out, and we will meet in person soon and on Zoom for this Journal Club review on Tuesday, August 11th at 6 p.m.